We're actually also doing a transradial hemodialysis access case. I want to go through the history real briefly. You guys can see the history slides?
Not yet.
Not yet. Okay. I think they're just getting set up for us. You just had the fluoro image. Okay, so we're not ready yet for that fluoro image. We were taking some preparatory images, getting access. Meanwhile, this is an 89-year-old male. Similar story, multiple cardiovascular morbidities, including coronary artery disease, diabetes, end-stage renal disease. He's had this left upper extremity radiocephalic fistula for many years. Multiple fistula interventions, a typical, we generally, as I'm sure Dr. Runback was mentioning, we bring the patients back on a routine maintenance schedule, approximately every 91 days or so. He has multiple pseudoaneurysms in the forearm. I'm not sure if the camera could zoom in on the forearm. Multiple areas of pseudoaneurysms in the forearm. And in looking back at all the cases, it was always a little bit difficult to see the exactly at the perianastomotic and juxtaanastomotic region. You know, oftentimes when you're doing these interventions, it's also just like the dialysis nurses like to puncture in easy areas. You know, I think we tend to do that as well. In this case, we wanted to try to do transradial. So access in this case was actually pretty easy, and we were expecting, based on our previous images from the prior studies, that there was going to be in the forearm cephalic venous outflow stenosis. I'm actually going to try to get you guys to see the review images. I just want to show the first set of images. Can you guys see this?
We can.
So that was a puncture. We started off, we wanted to use a 6 French cylinder sheath because I was expecting to potentially use 035 balloons, and using that 6 French cylinder sheath, it allows you to basically go up to whatever 6 French devices you can go to, including Viabonds, including really large 035 balloon catheters. And you see the wire going through the anastomosis there and going up the fistula. Let's see if we can get the next one. And we're going to have the first run right here, showing the multiple pseudoaneurysms with the area of relative stenosis as compared to the pseudoaneurysmal formation. And I always find that to be difficult. What do you guys utilize when you have a large area of pseudoaneurysm to decide whether or not the either proximal or distal vein is more stenotic?
So from the panel, thoughts from the panel? You know, I think personally you can look at flow volumes and then just measuring the absolute diameter. You really want to have at least a 6 millimeter channel to have a good conduit for a nurse to access.
Right. So, you know, in this case, obviously the second set of images, they're more more essentially up the arm, about the antecubital fossa, an area what we usually consider to be stenotic, and that's an area that we're going to likely treat. But then as I kept going up the arm, and that's where we're about right now, I'm going to take a better look.
Let me just take this out for a second, then I'm going to put it right back. I just want
you go ahead and 1 second while we try to get the more central shot, and that's what I'm about to do now. If you look at the central shot here, you see a lot of collaterals, and you know, we don't necessarily treat when you see all these different collateral veins, but there's something in the central venous system there that I'm noticing that I want to get a much better, closer look at, and that's where we're at right now in this case. And just want to get a sense from the panel also, when do you guys treat central venous stenosis in these dialysis access cases?
So, you know, I think when the arm has swelling, it's definitely an indication. It can make it very difficult to stick and treat. If there's going to be high venous pressures when they're on the machine, that's also an indication. But I would also get concerned when I see all those collaterals when you do that injection further down the arm. How about other thoughts from the rest of the panel?
The same. So if the nephrologists tell us that there's a higher reflux, we treat and we go for the central venous stenosis or the swollen arm on the occlusion.
Right. So he doesn't have a swollen arm per se, but we're going to go ahead. I'm going to ask him, Nota Spide, in my very excellent Spanish. And you guys could see that that's a pretty stenotic area. I wasn't not necessarily expecting that to see that. So I think we're going to go ahead and treat that area of stenosis. I'm going to go on a long Rosen. Long 035 Rosen, please. And we'll get a... want to give it 1060? Okay, that's not a bad idea. Let's go with we're going to go with an 018 system, actually. Let me have a long V18. And we're going to actually be able to use the profile of an 018 balloon catheter in order to treat this. Yeah, and we have a 6 French sheath in. So pretty much anything, we'll be able to use anything. And, I also, in doing these more central lesions, I also want to think about the next step if I'm going to need to stent and make sure that my sheath size will be available to accommodate any potential stents. So we're using an 018 V18 wire. I'm believing this lesion should be relatively easy to cross.
If I may, what symptoms does this patient have to warrant treating this lesion? And also, there's multiple papers. There's also papers that show that if they're asymptomatic and you treat this, you actually accelerate problems for these patients.
Yes, and that's exactly why I was asking the panel when they went ahead when they would go ahead and treat this patient. So he does have some multiple. The machine does have difficulty obtaining excellent dialysis for this patient, and he does have some left upper arm swelling. Okay, I need a long V18, please. And yes, we tend not to treat these, and that's exactly why I was wondering from the panel when they decided to treat this type of lesion. Yeah, Platinum Plus is good. So we're getting set now to treat that. And I would anticipate potentially going up to 12 in that area. And we'll see from there. Okay. Yep. One of the disadvantages sometimes of treating from the radial approach is also in terms of balloon length. Not so much sheath size, but balloon length typically, when you're using the shorter dialysis access balloons, can be difficult. Okay.
And what type of balloon are you going to use here?
So we're using here a Boston Scientific Sterling. It's an 018 balloon, goes through a 6 French sheath. And you could also see the pacer wires on the other side. And, we've had many patients that had pacer leads and end up with big central occlusions that became very difficult to recanalize on both sides. Yeah, you can go up. How long do you guys usually inflate for?
The thoughts from the panel?
3 minutes.
Yeah, for the panel. How long, a central lesion like this, you'll hold it up for 3 minutes?
3 minutes, yeah.
We
Yeah.
inflate at least
Okay.
2 minutes, 2 or 3 minutes. Yeah.
Yeah, I usually do 3 minutes as well
Yeah.
in the venous circulation. So I think at least 2 is the
Get a
consensus from
20
everybody.
with half and half. Yeah, so that's what we're going to be doing here, and we'll see what it looks like after. Now, I think this balloon may be somewhat undersized. What do you guys think?
Yeah, it seems like it could probably be a bit bigger.
Yeah.
Do you have
We have
any
a quote?
experience with cutting or scoring balloons?
I have experience. We've used it in the fistulas, usually in the perianastomotic region. I have not personally used it centrally in this area. And certainly in the periphery, in the arterial system, we've used it several times. But centrally, I don't believe I have an experience in it. Is that an area that you think this might be worthwhile treating?
Actually, so centrally not, but maybe at the end, at the beginning of the cephalic vein, maybe. But
Right. Yeah. Centrally, I haven't done that. So we have another minute or so on this inflation, and we shall see. Now, this is the first time that we're seeing this central venous lesion out of all the previous studies this patient has had. So it was actually kind of, as we're reviewing the cases and preparing them, a little bit unexpected finding. And given that his arm is a little bit swollen, like we said, we're going to go ahead and treat that to prevent further swelling.
And how many prior interventions has he had, as this gentleman had on his fistula? Has this been a ongoing recurrent stenosis?
This has been ongoing. He's on our maintenance. Yes, this has been a recurrent stenosis, and like I said, this is the first time that when I went back, we have the 3 of us here, so we each sort of take turns doing our hemodialysis access, and all of the interventions previously have been in that forearm. Cephalic outflow in the in the pseudoaneurysm region before and after them. And on today's visit, it was actually quite a bit better than the previous one from about 91 days ago, which is their maintenance regimen. I think that has to do with insurance purposes as well as other factors. But he's been on our maintenance regimen for the last 2-3 years, so that would be multiple interventions.
So maybe I can query the panel to ask, at what point in a patient that is still having successful maintenance of fistula function, but was requiring every 90 days every intervention, at what point would you consider referral to surgical revision?
We can go down.
So, Theodosis, or
I think after 1 or 2, after 2 re-intervention, I think it is a time to do the open revision.
Same for me. 1-2 times of interventions, and then I think it's not efficient. Go on for that.
about
Now, in a patient like this, what sort of revision would you guys be looking for exactly? So, it's an 89-year-old gentleman who's undergoing maintenance hemodialysis. To undergo even a minimally invasive surgical intervention, I would potentially argue might, although would potentially prevent him from coming back so often. He's not coming with a clotted access.
I think one potential
Hope
option is to take where the outflow is good at the brachial and just bring that to the radial artery a little more proximal or to the brachial artery, and now just convert it to an upper arm fistula where you're above the areas of continued recurrent stenosis would be one surgical option.
Right. Sure.
How many of the panelists would
half and half.
would have put a covered stent in through these recurrent areas as opposed to continued angioplasty? Anybody on the panel who would put a covered stent in for this?
This is difficult to say. There's not enough data, I would suppose. And in this clinical situation, he can come back several
No
times.
respire. So now we have a not a great looking result there. What we're going to go ahead and do is let me have a TUI, and I'll have the catheter come back. Okay.
What do you think that is a problem?
Closer look. I'm not sure yet. What I want to do is I want to get a closer look centrally. Because I'm injecting from the radial access.
Maybe a question, what's your anticoagulation regimen during the procedure?
Yeah, right. Typically, we don't use any, unless we're doing a declot, we don't use any anticoagulation. Okay. Maybe you should. In this case, this doesn't look like a thrombotic event. I'm not sure. We'll find out. I need that on the back. And we're going to go ahead, we'll investigate and...
Working on this. I think one option is go to a talk and then go back. So why don't we, we'll see what it looks like here with an aspiration, and maybe what we can do is go to the first talk and then switch back and see how you're coming along. How's that sound?
Absolutely.
So why don't we go ahead?
Sounds good to us. Right.
Welcome back.
We did a prolonged balloon inflation in that location. I also was able to get the catheter. One of the things I like to do, especially when I have an 018 wire, is take an 035 catheter and put a TUI on it with a flow switch at the back. And this way get a good sense of what exactly is going on in the venous abnormality in this case, or sometimes we do that in the arterial system as well. I did 2 runs after, which we're still seeing sluggish and almost no flow through that area. So this is now a run after prolonged venous angioplasty. And we're still finding pretty much the same findings. So I think what we're going to have to do is go ahead and put a central stent in that location. I'm going to go, and one more time, take the Berenstein catheter with the TUI at the back of it, just to inject in that location, showing that it actually is patent in that area. We did give the patient 3,000 units of heparin, but typically in our standard interventions that are not thrombotic cases, we don't usually use, can you loosen that? We do not usually use any sort of anticoagulation protocol. Is that something that you guys use standard in, either in the outpatient setting or
from the panel, I know I personally always use systemic anticoagulation on such a big drawback. How about the rest of the panel?
I would put him on heparin, of course. If you think of 3 minutes balloon inflation
so we did
in
that.
a low flow system, this is kind of dangerous for thrombosis.
Yeah. We generally don't have that problem. So you see there, what do you think about that finding, guys?
So we have the ultrasound
there's some
image
acute
again.
thrombus in there? You're not seeing the...
We're not seeing the fluoro right now.
All right, let me see if they can get the fluoro. Can you guys get the fluoro picture for them? You want to get them? Hang on, guys. We're hoping that it'll come back up.
So another question
We're waiting for them to...
on anticoagulation, will your
Can you guys see it yet?
Coagulation regimen change when you should insert the stent or not?
In terms of